Stepwise approach to laparoscopic removal of type 2 cesarean scar ectopic pregnancy. The authors have no conflict of interest to disclose. The objectives of this video are to review the definition of a CSEP, describe the indications for laparoscopic resection, and to demonstrate a surgical approach to laparoscopic resection. CSEP occurs when a pregnancy implants in a myometrial defect caused by dehiscence of the lower uterine segment cesarean scar. Rates are estimated at 1 in 1,800 to 1 in 2,500, and incidence increases as cesarean section rates increase. Potential outcomes, particularly if unrecognized, may include catastrophic bleeding, massive transfusion, and emergency hysterectomy. In this video, we present a case of a 39-year-old G4P3 with 3 previous cesarean sections and suspected CSEP on her dating ultrasound. Further characterization demonstrated an overlying myometrial thickness of only 1 millimeter. This was a wanted pregnancy and she desired fertility in the future. There are multiple classification systems of CSEP, but no accepted superior method. The earliest and perhaps most well-known is that where type 1 describes superficial implantation and growth inwards, whereas type 2 describes deep myometrial implantation and growth outward towards the abdomen. A recent study published in Obstetrics and Gynecology presents a more granular classification system whereby both gestational sac size, GS, and anterior myometrial thickness, AMT, are defined as independent risk factors for hemorrhage. The CSEP in our patient with an AMT of less than 1 millimeter and GS presumed to be between 30 to 50 millimeters is classified as a type 2 to 3. Previous literature has recommended a laparoscopic approach for CSEP beyond a type 1. In the case of a CSEP with thin overlying myometrium, we can look at a mathematical formula to appreciate the stress on the thin myometrium. In this formula, the stress sigma is equal to the pressure P multiplied by the radius R, divided by 2 times the thickness T. Therefore, as the pregnancy develops, the enlarging radius and pressure of the gestational sac, combined with a thin overlying myometrium, such as in our case, exerts increasing stress on the myometrial wall, leading to potential rupture and catastrophic outcomes. In the video, we present a 4-step approach to laparoscopic removal of cesarean scar ectopic pregnancy. Step 1. Inspection and visualization of CSEP. Step 2. Incision and dissection of vesicouterine peritoneum, including mechanical hemostasis with temporary uterine or internal iliac artery clamping, then placement of a uterine manipulator, finally chemical hemostasis with vasopressin. Step 3. Dissect pregnancy and isthmocele. Step 4. Repair of uterine isthmocele. The cesarean scar ectopic pregnancy is easily identified as a bulge just cephalad to the bladder peritoneum. We plan to place bulldog vascular clamps prior to developing the bladder flap or placing a uterine manipulator to reduce the risk of significant bleeding. We initially started with an anterior approach to dissecting into the retroperitoneum. The paravesical space was developed on the right to attempt to identify the ureter and uterine artery. Due to the patient's BMI of 35 with a central distribution and significant vascularity as expected in a 9-week gravid uterus, the anterior approach was abandoned. However, the internal iliac artery was identified with a tortuous branch of the uterine artery. A lateral approach was then undertaken. Note the previously dissected paravesical space on the right, the round ligament, and the lateral dissection to identify the ureter and internal iliac artery. The internal iliac artery was isolated and then grasped to facilitate placement of a vascular bulldog clamp. The right ureter was reflected medially as the bulldog clamp was introduced. With the clamp securely in place, attention was turned to the left side. Note the extensive vascularity and 9-week gravid size of the uterus. Again, we started with an anterior approach, dissecting the paravesical space, noting the location of the uterine artery. Again, the adiposity and vascularity made dissection challenging. We proceeded with a lateral approach to the ureter and internal iliac artery on the left. The artery was isolated with great care and a bulldog clamp was placed without complication. Securing the internal iliac arteries bilaterally provided a mechanical hemostasis prior to introducing a uterine manipulator. In this case, a Volchev manipulator was used only after the arteries were secured so as to limit potential hemorrhage. The vesicouterine peritoneum is now dissected, and the previous development of the paravesical spaces bilaterally facilitated this significantly. There's minimal tissue left to finish the bladder flap. With the bladder peritoneum dissected, the bulge is even more obvious. The boundaries of the pregnancy are demarcated with an ultrasonic device prior to any distortion of the anatomy. The outer edges of the pregnancy are then infiltrated with vasopressin via a spinal needle transabdominally. The dissection of the cesarean scar-ectopic pregnancy was then initiated. Care was taken in an attempt to follow the spherical gestational sac to avoid resection of normal healthy myometrium. The overlying myometrium was confirmed to be quite thin, and we encountered the gestational sac quickly. Fluid was suctioned from the gestational sac and placental tissue was identified and removed. The fetus was then encountered and removed. The footage for this part of the procedure has been intentionally omitted. A specimen retrieval bag was preemptively placed into the abdomen to retrieve tissue. We continued to excise the isthmoseal from the surrounding myometrium. The bleeding was extremely minimal due to the mechanical hemostasis with the bulldog clamps and chemical hemostasis with the vasopressin. We did, however, encounter venous bleeding, requiring suturing to obtain hemostasis. There was a total estimated blood loss of only 30 cc's throughout the case. The isthmoseal was further dissected from the anterior aspect, again taking care to follow the direction of the isthmoseal rather than a perpendicular wedge that would resect a significant amount of normal myometrium. Inspection of the isthmoseal dissection site confirms complete excision. The uterine manipulator helps to clearly define the anterior and posterior walls during closure. A barbed suture was used to close the hysterotomy in a double-layer approach. This patient desired future fertility, and therefore strong closure of the defect was of utmost importance. The specimen retrieval bag with the pregnancy and the isthmoseal tissue was then removed through the 10mm umbilical port. The bulldog clamps were then taken off bilaterally with great care to not disrupt the internal iliac arteries. Hemostasis was confirmed abdominally at low pressure as well as vaginally. In this video, we demonstrated a stepwise approach to laparoscopic removal of a type 2 CSEP. Thank you for watching.